So, welcome everyone. My name is Peter Hendricks. I'm an interventional endoscopist here at the University Hospital of Ghent, and I am very happy to introduce this first Geeks webinar on HPB disease. We will plan two other events this year, and the final aim is in fact to really have to create an online curriculum for HPB disease also on the Geeks website. And this online platform will definitely help you to learn more about training, the techniques of basic ERCP, and then also some more advanced procedures. So we have chosen as the first subject biliary cannulation, because this is of course the basics of ERCP. And I'm very happy that I have two colleagues also with me. The first one is Enrico Palmeghi. Enrico Palmeghi is a fellow in advanced ERCP and EOS at our unit. And of course, since he has done his basic ERCP training quite not so long ago, he is in a very good position to talk a bit more about basic cannulation techniques. And then we also have Raymond McDon. He is working at the Royal Bournemouth Hospital. He is responsible for the HPB service over there. And Raymond has really a lot of experience in training people in ERCP and EOS. And he is also highly involved in quality projects concerning HPB endoscopy. So I'm very happy that he is also here to join this webinar. Just a final thing to say before we get started. If you want to interact, if you want to ask questions, then you need to log in through Zoom. So it's not possible through the Geeks website. So go to Zoom if you want to ask questions. If you just want to watch and listen, then you can just stay on the Geeks website. With this, I would like to give the word first to Raymond McDon.
Okay, thank you very much, Peter, and thank you for asking me to talk for this evening's symposium. So I am going to try and share my screen, which I hope is going to be screen 2. And then we will start the ball rolling. So so just give me one moment. Okay. How does that look for you guys?
We don't see it yet.
All right. Okay. So
maybe it's best to do share and then just.
Oh yes, got you. Okay. So I'm going to share now.
Yeah.
How does that work?
Excellent. Yeah. Thank you.
All right. So defining the ERCP training pathway. So the learning lecture objectives really for this short session is what is the ERCP? How hard is it to learn? Defining the training pathway to ERCP. So they're fairly short objectives. So ERCP combines endoscopy and fluoroscopy at the very basic level, and it is designed to treat problems in either the biliary and or the pancreatic ductal systems. I would say that that's probably it in a nutshell, and it involves benign as well as malignant disease. So what is the ERCP in more detail? So it's about gaining access to these biliary and pancreatic ductal systems. It's not really just about endoscopy. It involves interpreting previous radiology studies, because it is that patient journey through radiology with a transabdominal ultrasound or endoscopic ultrasound or CT or MRCP that brings them to you for an ERCP. It also involves imaging and fluoroscopy. It has so many different layers to it, such as communication, planning. Patient information is paramount, and this leads to a really good, robust consent. Consent is critical in ERCP. And I've got a very personal feeling about consent, and that is learning how to calculate the personalized risk that the General Medical Council call. Complications happen in ERCP, and that's really why we reference back to really good and robust and clear consent. trainees may be exposed to complications in their training and subsequent practice. And we can talk about this if there's time allowing at the end. So how hard is the ERCP? Well, I think it's hard. It doesn't need to be. And I'm going to talk about the Schutz classification, which is grading the difficulty of different types of ERCP. The main thing that there is a modified Schutz, but I'm just going to talk about the basic one. And for the trainee, at least in the United Kingdom, we focus on grade 1 and grade 2 levels for training, for the entire training. After a person has been credentialed and is able to work and is good for independent practice, then they will have exposure to grade 3 and grade 4. So grade 1 is deep cannulation of the duct of interest through the main papilla or sampling. Biliary stent removal or exchange. Grade 2 is about taking stones out of the common bile duct, which are 10 or less than 10 millimeters in caliber. Treating biliary leaks, treating extrahepatic strictures, so that's strictures in the bile duct below the level of the liver hilum, and placing prophylactic pancreatic stents. So what's grade 3? So this is biliary stone, and I've grouped this more or less towards things in the bile duct and then in the pancreas. So stones that are greater than 10 millimeters are level 3. Removal of stents that are migrated are in this level of difficulty. Intraductal imaging, biopsy or fine needle aspiration, treatment of hilar tumors, treatment of benign biliary strictures in the hilum or above. Management of suspected sphincter body dysfunction is probably less prominent now, and certainly should not be, a case should not be put in front of a trainee or someone who's just been recently credentialed